Welcome CyberMDs to another cardiology lecture for our USMLE Step 2 videos. Today we'll be discussing hypertension. Before we start, please remember to like, comment, and or subscribe so that we can continue to provide free medical education resources for students everywhere. Now, let's get started. On this slide, I've just provided a brief lecture overview, so we're going to do a bit of an introduction into hypertension, talk about diagnosing it, categorizing it, as well as managing it. And that's all going to be for primary hypertension. We're also going to do a small pharmacology review and talk about secondary hypertension as well. So, hypertension, commonly known as high blood pressure, is a condition where the force of the blood against the walls of our arteries is too high. Clinically, it's going to be defined as having a systolic blood pressure greater than 140 millimeters of mercury systolic, or a diastolic pressure greater than 90 millimeters of mercury. Remember that blood pressure readings are not static, it can vary throughout the day, so diagnosis often requires multiple readings under standardized conditions. One of the most insidious aspects of hypertension is that it's often a silent disease. Many patients with high blood pressure exhibit no symptoms, and they may remain unaware of their condition for years. This lack of symptoms is why regular blood pressure screenings are crucial. Hypertension doesn't really occur in a vacuum either. It's often interlinked with other risk factors like obesity, sedentary lifestyle, high salt intake, tobacco use, excessive alcohol consumption. Genetic factors and age can also play a significant role, and understanding all of these risk factors is key in both prevention and management. The reason why we emphasize hypertension so much is due to its complications. Chronic high blood pressure can lead to atherosclerosis, which in turn can lead to the increased risk of heart attacks and all sorts of other things that we're going to discuss later. But these complications can significantly impact a patient's quality of life and longevity. Our management goals in hypertension are going to be threefold. We're going to talk about risk factor modifications, prevention, and long-term management. So those are going to be that's our three-pronged approach to managing hypertension in our patients. So risk factor modification, talking about diet modification, lifestyle modification, regular exercise, reducing sodium intake, managing stress and cholesterol levels, all of those things. Preventative strategies are going to be crucial, especially if patients are at high risk for developing hypertension. So thinking about things such as a family history or family history of cardiovascular disease, those are going to be crucial in identifying these high-risk patients and who we should try and prevent hypertension. And then finally, long-term management is going to be essential for patients who are diagnosed with hypertension. That's often going to involve a combination of lifestyle changes as well as medications after they've been diagnosed. And we'll talk about what medications later. Before we get too far off into the weeds, though, let's define hypertension. So again, we talked about the systolic blood pressure greater than 140 or diastolic greater than 90, but it's also essential to distinguish between primary and secondary hypertension. Primary hypertension is the most common type, and that's going to occur in about 90 to 95% of people who have cases of hypertension. And that's going to be diagnosed when the blood pressure is not going to be attributable to any specific cause. It's a chronic condition, and it's often related to lifestyle and genetic factors. Secondary hypertension, on the other hand, is going to account for 5 to 10% of hypertension cases, and it's going to be due to identifiable causes such as kidney disease, endocrine disorders, medications. And so it's going to be really crucial to identify and treat the underlying cause in patients with secondary hypertension. The diagnosis of hypertension typically involves measuring blood pressure on at least 2 separate occasions. Blood pressure readings are going to be categorized as normal, elevated, stage 1, or stage 2 based on specific systolic and diastolic values. So what we talk about when we talk about blood pressure monitoring is ambulatory blood pressure monitoring. And that method involves a patient taking home a blood pressure cuff or purchasing one and measuring their own blood pressure at regular intervals throughout the day and night at their house. The advantages of ambulatory blood pressure monitoring is that it provides a more accurate representation of a patient's blood pressure throughout the day, capturing those variations and reducing the possible impact of white coat hypertension, where patients exhibit elevated blood pressure in a clinical setting, but not in their everyday environment. The disadvantages, however, is that it can be inconvenient, it can be uncomfortable for some patients, sometimes it's more resource intensive, and additionally, it requires thorough patient education and understanding on cuff placement and the procedure for taking a blood pressure. Finally, we're going to talk about JNC 8 guidelines a little bit more in depth momentarily, but the current guidelines are that for individuals age 60 and older, there's a certain blood pressure target, and then less than 60, there's a certain blood pressure target. And the JNC 8 guidelines really kind of help us clinically to influence our treatment goals and our strategies. They talk about different medications to use and what patient populations to use those in. And so in a clinical setting, it can help us decide when to initiate treatment, how to set safe blood pressure goals and targets for our patients, and possibly which medications to use. However, what these guidelines don't do is they don't tell us when to screen. So the USPSTF guidelines, as of the making of this video, state that anyone over the age of 18 should be screened for hypertension. And people are anytime they visit a doctor's office because they're going to receive a set of vital signs at that time. And so make sure you're up to date on the current USPSTF guidelines for blood pressure screening because, like I said, as the making of this video, patients age 18 and older should be screened, but these things change through time as more data comes out and more trials come out and more studies come out. So make sure you're up to date on those things. Next, let's focus on the categories of hypertension. So we have normal, which is going to be less than 120 systolic and less than 80 diastolic. We're going to have elevated, where the systolic rises to 120 to 129 systolic. And then we're going to have stage 1, where the systolic continues to rise, this time from 130 to 139. And then the diastolic also rises here, and it's between 80 and 89 diastolic. Then we have stage 2, where both continue to rise and you have at least 140 systolic and at least 90 diastolic. And then we get into this row that says urgency and emergency. So let's discuss hypertensive urgency. This is going to be a condition characterized by a systolic blood pressure greater than 180 or a diastolic pressure over 110. But the key point here is that despite these really high readings, there's no evidence of end organ damage. There's no evidence of renal damage. There's no evidence of hepatic damage. And this might seem really counterintuitive given just how high these blood pressure values are, but it's a very crucial distinction from hypertensive emergency. So in the management of hypertensive urgency, our approach is relatively conservative compared to hypertensive emergency. The primary goal here is to lower blood pressure gradually over hours to days, and that can typically be achieved with oral antihypertensive medications. And so it's important to avoid overly or rapidly reducing the blood pressure in patients with hypertensive urgency, and that's going to prevent ischemic complications. Commonly used medications are going to include beta blockers like labetalol or calcium channel blockers. The choice of medication is probably going to depend on the patient's overall health, their existing comorbidities, and things of that nature. But all in all, you should just be reducing this over hours to days. And that's, I think, a very crucial thing for you to remember clinically. So now let's talk about the other side of this coin, which is hypertensive emergency. And so this is a little bit more severe of a condition. We see the blood pressure exceeding the 180 systolic and the 110 diastolic, but unlike hypertensive urgency, we see evidence of end organ damage. There might be renal damage. There might be hepatic damage. We see end organ damage. It can also manifest as heart failure or a stroke or a myocardial infarction. And so managing this is very, very crucial, and understanding management of this is very crucial clinically. And so what we want to do is obtain the immediate goal of reducing the mean arterial pressure, or MAP, by no more than 25% within the first hour. And that's going to be your initial reduction goal. And that's going to help mitigate the risk of further end organ damage, but but it's also going to balance mitigating that risk with harming the patient by reducing it too quickly. So IV medications are typically used to obtain that initial goal. They're easily titrated and they have a rapid onset of action, and so they're ideal for that purpose. So you might see IV nitroglycerin or nitroprusside. You might see IV labetalol used. These are all going to be choices in various clinical scenarios based on the patient and how they're presenting. And then after that initial management, you're going to achieve a more stable blood pressure over the next 24 to 48 hours, usually done with some sort of transition to oral antihypertensive medications. And you're going to be carefully monitoring for any signs of worsening end organ damage throughout that whole time. So I hope I've given you a pretty good background on hypertension and where this lecture is going, and we've discussed management of hypertensive urgency and emergency, which are the really bad acute things for hypertension. But let's talk about chronic hypertension, chronic primary hypertension, and the management guidelines for that. So we're going to be following those JNC8 guidelines that I mentioned, and those state that for patients age 60 and above, the target blood pressure is less than 150/90. The adjustment in that reflects an understanding of the risks and benefits of treatment in that age group. And then for patients under the age of 60, for those individuals, the goal is a little bit more stringent, set at less than 140 systolic/90 diastolic. That target's consistent across various patient populations, including those with diabetes and chronic kidney disease. So let's move on to medication strategies. The JNC8 guidelines offer a simplified approach, but it's still vital to tailor the treatment to each patient's unique needs. The general approach is that the choice of initial antihypertensive therapy should be based on the individual patient's health profile, including comorbid conditions, and it's not just about lowering that blood pressure, but doing so in a way that's safe and most effective for the patient. And so they recommend 4 classes of medications as first-line therapy. 1, thiazide diuretics. 2, calcium channel blockers. 3, angiotensin-converting enzyme inhibitors. And 4, angiotensin II receptor blockers. And those last 2 are going to be ACEIs or ARBs. The choice among these options should be based on the patient's, again, specific health conditions. Remember that the guidelines recommend initial treatment should include thiazide diuretics and calcium channel blockers and ACE inhibitors and ARBs, and that's going to be in the general non-African American population. But we're talking about providing a tailored approach, and so remember that for the African American population, the recommendation is going to be starting with a thiazide diuretic and or a calcium channel blocker. Remember that those 2 medications or classes of medications specifically are shown to be more efficacious and effective in the specific African American population. Next, you want to make sure you're doing some special considerations or taking some things into consideration, such as chronic kidney disease. And so for patients with CKD, regardless of their age or race, you're probably going to want to put them on an ACE inhibitor or an ARB as a part of their first-line therapy. Reiterating again, the African American race should typically get a thiazide type diuretic or a calcium channel blocker as a part of their initial treatment, and you should be closely assessing how well they respond to that. And it's not a cookie cutter approach just because of their race. You want to make sure that that's still actually efficacious for that single patient and make sure they're responding appropriately to that. And if they aren't, trying a different approach, maybe subbing one of those 2 out for an ACE inhibitor or an ARB. And then finally, in our elderly population, no matter the race, it's going to be crucial to balance the benefits of lowering the blood pressure with the potential risks of treatment, such as falls due to orthostatic hypertension or something along those lines. So a more cautious approach in the elderly population may be warranted, often starting with lower doses and then gradually titrating up. All right, now let's dive into a bit of a pharmacology review for the management of hypertension. And so let's start with one of those cornerstone drug classes, thiazide diuretics. So these meds are going to play a pivotal role in the management of hypertension in a lot of the patients that you'll see. So let's talk about the mechanism of action first. It's primarily going to act on the distal convoluted tubule in the kidneys, and the primary mechanism is going to be inhibiting the sodium chloride symporter in that segment of the nephron. And in doing so, it's going to reduce sodium reabsorption, which leads to increased excretion of both sodium and water. And so that diuresis effectively decreases blood volume, which in turn reduces the cardiac output and lowers blood pressure. Additionally, thiazides are going to have a vasodilatory effect on the peripheral vasculature, which further helps in reducing blood pressure. Thiazide diuretics are primarily indicated for patients in the management of mild to moderate hypertension. They're often going to be the first-line treatment, as we've discussed with the JNC8 guidelines, especially in those patients without any other compelling indications for any other types of drug classes. And then additionally, you're going to use those in thiazide diuretics. When I say those, you're going to use these in the management of edema associated with congestive heart failure or liver cirrhosis or chronic kidney disease. So keep that in mind as possible comorbid conditions that would also indicate a thiazide diuretic in patients who have hypertensions. And while these are generally going to be safe medications, there are certain conditions where their use is contraindicated relatively or completely, and therefore they should be used with caution or not at all in those patients. So patients who have severe renal impairment, who maybe have a hypersensitivity to sulfa drugs. So if they have a history of a sulfa allergy, there may be cross-reactivity with thiazide diuretics. Patients with gout can have an exacerbation of their gout due to increased uric acid levels. Patients with diabetes, as it can affect glucose tolerance, and so they may require anti-diabetic medication adjustment if you're going to place them on a thiazide diuretic. It can also cause electrolyte imbalances to worsen, so patients who have underlying electrolyte imbalances, you may want to think about not prescribing them a thiazide diuretic. And then, as always, we're going to talk about side effects briefly of thiazide diuretics. They're typically very well tolerated, but there's several key things to monitor for. One, those electrolyte imbalances that we just mentioned. Two, hyperuricemia, which is relative to the gout, which we discussed. Three, hyperglycemia. Four, hyperlipidemia. 5, increased calcium reabsorption, which could be beneficial in preventing osteoporosis, but can lead to hypercalcemia in an individual who's predisposed to that. And then other side effects can include dizziness, photosensitivity, and very rarely that allergic reaction, usually in patients who have a history of allergies to a sulfa drug. All right, next up is calcium channel blockers, particularly dihydropyridines like amlodipine and nifedipine. And those are going to be working by inhibiting the influx of calcium ions through L-type calcium channels in the vascular smooth muscle. This action leads to vasodilation, primarily in the arterioles, which reduces peripheral vascular resistance and subsequently lowers the blood pressure. It's important to understand that these agents act selectively on the vascular smooth muscle and have a much lesser effect on the heart compared to non-dihydropyridine calcium channel blockers. They're particularly beneficial in patients who require significant peripheral vasodilation, such as those with isolated systolic hypertension. Additionally, these agents are indicated for the treatment of chronic stable angina and certain forms of vasospastic angina as well. And then due to their vasodilatory effects, they're often used also in patients who have Raynaud's phenomenon and certain forms of migraines. And so while we may use them and they may be indicated in those patients and they're generally safe, there are certain conditions where their use is contraindicated or should be approached with caution. And those can include hypotension, so given their blood pressure lowering effects, they should be avoided in patients who have significant hypotension. And then heart failure, particularly in cases of heart failure with reduced ejection fraction, as they can exacerbate that condition. And then caution is also advised in patients with severe hepatic impairment because the drugs are metabolized in the liver. So we've talked about indications and contraindications and the mechanism of action, so let's talk about the side effects. The side effect profile of dihydropyridine calcium channel blockers is relatively well tolerated, but there are some common adverse effects that we're going to discuss, such as peripheral edema, which is one of the most common side effects due to the vasodilation of those peripheral arterioles. 2 is headache and flushing, again due to that vasodilation. 3 is dizziness and palpitations. These can occur, but will occur particularly at the initiation of therapy or with dose escalation. And then 4 is a reflex tachycardia, and although this is less common with the newer, longer-acting formulations that we have, this can occur due to a compensatory increase in the heart rate in response to the vasodilation provided by the medication. And then lastly, remember that these can cause a gingival hyperplasia, and it's going to be relatively rare, but it is going to be a notable side effect, especially with long-term use of these medications. All right, next let's talk about ACE inhibitors, ARBs, and ARNIs. So for ACE inhibitors, those are going to work by inhibiting the angiotensin-converting enzyme, and that inhibition is going to lead to a decrease in the production of angiotensin II, which is a potent vasoconstrictor. So the result of that is vasodilation, which in the end is going to reduce blood volume and ultimately lower blood pressure as it vasodilates. Additionally, these medications are going to reduce the degradation of bradykinin, which is also going to contribute to vasodilatory effects. They're going to be used in patients who have hypertension, obviously, as we're discussing them now, but also they're indicated in patients with heart failure, who have had a myocardial infarction, or who have diabetic nephropathy due to their renal protective effects. However, they will be contraindicated in patients who have a known hypersensitivity to ACE inhibitors. Maybe they have a history of angioedema related to previous ACE inhibitor therapy. They're also contraindicated in patients who have a known bilateral renal artery stenosis, and they're also contraindicated in pregnancy due to teratogenic effects. Their side effects can include a dry cough, a hyperkalemia, renal impairment, as well as angioedema. And although the angioedema is rare, it is a serious adverse effect requiring immediate cessation of the drug. Next, we're going to talk about the angiotensin II receptor blockers, or ARBs. ARBs selectively block the binding of angiotensin II to the AT1 receptor, and that blockade prevents the vasoconstrictor and aldosterone-secreting effects of angiotensin II. So unlike ACE inhibitors, ARBs do not increase bradykinin levels. That's going to be a major difference based on the mechanism of action. These are going to be used again in patients with hypertension and heart failure, in patients who have had a recent myocardial infarction, and they're also going to be used in patients with chronic kidney disease. The contraindications to ARBs are going to be a known hypersensitivity, pregnancy due to the risk of fetal harm, and also you should cautiously use these in patients who have renal artery stenosis. And then the side effect profile for ARBs is going to include dizziness and hypotension, hyperkalemia, similar to ACE inhibitors. They're less likely to cause cough and angioedema, but it is still possible, so think about those things. Angiotensin receptor neprilysin inhibitors, or the ARNIs, are going to be a combination of an ARB as well, so an ARB, angiotensin receptor blocker, and a neprilysin inhibitor. Neprilysin is an enzyme that degrades natriuretic peptides, bradykinin, and adrenomedullin. Inhibition of neprilysin increases the levels of those peptides, enhancing their beneficial effects on the heart and blood vessels and giving you some vasodilation. So indications for these medications would include hypertension, heart failure with reduced ejection fraction, and they're going to be contraindicated in patients similar to ARBs, which is going to include patients who have a known hypersensitivity, patients who are pregnant, and they shouldn't be used concurrently with ACE inhibitors or within 36 hours of the last dose of an ACE inhibitor. Their side effects similarly can include hypotension, hyperkalemia, and an increased risk of angioedema. So that's going to be our pharmacologic review for ACE inhibitors, ARBs, and ANRIs. I think it's really important to understand the difference in the mechanisms of these drugs, as that's an easy way they can trip you up on exams, as well as knowing how those things affect the normal physiology, how those mechanisms affect normal physiology, as that's also an easy way likely that they can trip you up on an exam by asking about mechanisms of action. Next up is loop diuretics, such as furosemide, which are all going to work primarily by inhibiting the sodium-potassium chloride cotransporter in the thick ascending limb of the loop of Henle within the kidneys. And that action leads to a decrease in the reabsorption of sodium and chloride, and consequently an increase in the excretion of water, sodium, chloride, magnesium, and calcium. And so by promoting diuresis, these drugs effectively reduce blood volume, which in turn lowers blood pressure. It's important to understand that the diuretic effect of these drugs are really potent, making them effective and rapidly decreasing fluid overload. And so they're going to be indicated in patients with hypertension, heart failure, especially acute exacerbations of heart failure, patients who have renal impairment, and patients who have significant peripheral edema. They're going to be contraindicated, however, in patients who have allergies to sulfa drugs. You may want to be careful, as there can be that cross-reactivity here as well. Patients who have anuria, so if they're not producing any urine, the loop diuretics are potentially going to be ineffective, and so the only thing that can come from them is potential side effects, which is potentially just providing harm to your patient with no actual benefit of the drug itself. It can cause electrolyte imbalances, and it is also possible that it can exacerbate pre-existing electrolyte imbalances. So be careful in patients who have underlying electrolyte imbalances. Finally, it can be contraindicated in patients who have a pre-renal azotemia, and so it's advised that due to the risk of exacerbating that, you potentially not give it to those patients. Side effects can include, again, that electrolyte imbalance, can include dehydration. Remember, we're diuresing these patients, so it can include dehydration or hypovolemia. It can also include an ototoxicity. This is pretty rare, but it can be very serious, especially with rapid IV administration or if you're using it in combination with other ototoxic drugs. So remember what those are and that this is one of them. And so if you see a patient who has hearing issues and they're on a loop diuretic as well as some other ototoxic drug, consider this as an etiology of that ototoxicity. Next, it can cause a hyperuricemia, which can exacerbate gout, and then it can also cause a metabolic alkalosis due to the excessive loss of chloride in relation to bicarb. All right, last up in our pharmacology review is going to be beta blockers. And their function is primarily, or mechanism of action is primarily blocking of the beta adrenergic receptors in the heart and the blood vessels. And that action is going to lead to a decrease in heart rate, cardiac output, as well as the release of renin from the kidneys. And so by reducing the heart rate and the force of the heart's contractions, beta blockers effectively lower blood pressure. They also have a role in diminishing the sympathetic nervous system's response, which is often elevated in hypertension. And so their indications for use are going to be in patients with hypertension or coronary artery disease, patients who have had a previous myocardial infarction, because remember, these drugs also reduce myocardial oxygen demand. These are going to be indicated potentially in patients with heart failure, as well as patients who have certain arrhythmias. Additionally, beta blockers can be indicated in conditions such as hyperthyroidism or migraine prophylaxis, certain types of tremors, and so this is a very versatile class of medications. And while they're generally safe and very versatile, they do have contraindications, including asthma or COPD, as they can exacerbate bronchoconstriction. Patients who have severe peripheral arterial disease, they can worsen symptoms of claudication. Patients who have a decompensated heart failure, particularly these non-selective beta blockers, they can worsen the condition if a patient has decompensated heart failure. Patients who have bradycardia and other certain types of heart block, it's contraindicated in those patients due to their effect on the slowing of the heart rate. And so it's crucial to evaluate a patient's overall health and think about comorbid conditions before initiating therapy for or with a beta blocker for hypertension. Side effects can include fatigue and drowsiness, cold hands and feet due to reduced peripheral flow. It can include sleep disturbances, bradycardia, GI disturbances, and then some less common but more serious side effects include, again, that worsening of heart failure symptoms and severe bradycardia or heart block, and potentially severe hypotension, especially if a patient is very volume depleted and is administered a beta blocker. So think about all of those things when we think about beta blockers. Think about all the ways they can interact with other things. And also, for your own edification, I highly recommend going up and reading about beta blocker toxicity, as it can present pretty uniquely, often in the emergency department. So we've talked a lot about all of our pharmacologic options, and I just wanted to take this time to remind you that you should take an individualized approach with these patients, and you should tailor hypertension treatment to individual patient characteristics. And that's really crucial in treating hypertension. So age, race, comorbid conditions, drug tolerance, those are all going to play a very significant role in determining the most appropriate medication regimen. Comorbid conditions, for example, the use of ACE inhibitors in patients with diabetic patients. That's going to be things you should consider. Age factors, elderly patients, they may require a different approach. So make sure you're monitoring and adjusting the medications as needed. Make sure these patients have regular follow-up and can get access to care so that you can monitor for side effects, make adjustments, and have that goal-oriented treatment. Remember that ultimate goal is to achieve and maintain those target blood pressures set forth by the JNC8 guidelines. All right, so everything we've talked about so far is about primary hypertension. So secondary hypertension occurs when a patient's high blood pressure, again, is a direct result of a specific and identifiable underlying condition. That contrasts with primary hypertension, where we don't know what the exact cause is, or it's often unknown for some time. And so identifying secondary hypertension is critical. Again, remember, it accounts for 5 to 10% of all hypertension cases. And it should be suspected in very certain scenarios. So blood pressure in a previously normotensive individual, or hypertension onset at a young age, particularly before the age of 35, maybe severe or resistant hypertension that doesn't respond to standard treatment, or hypertension with a sudden increase in blood pressure from baseline. These clinical scenarios can hint at secondary causes of hypertension. And so the presence of those clinical signs or symptoms of any other underlying condition, so hypertension with signs and symptoms of something else, should also prompt evaluation for secondary hypertension. So let's discuss some common causes very quickly of secondary hypertension, which can include chronic kidney disease and end-stage renal disease. It can include hypercalcemia. Remember that elevated calcium levels can increase blood pressure by various mechanisms, including increasing the vascular resistance and altering the function of those vascular smooth muscle cells. So if they have symptoms like fatigue, muscle weakness, a history of kidney stones, maybe consider hypercalcemia. Conn syndrome, or primary hyperaldosteronism, is another notable cause. It's characterized by excessive production of aldosterone, leading to sodium retention, potassium excretion, and water retention, which will raise the blood pressure. And patients may present with weakness and headaches, and in severe cases, even maybe a periodic paralysis. Remember and always consider for secondary hypertension a pheochromocytoma. Remember, that's a rare tumor of the adrenal medulla where you're excreting excess catecholamines, causing episodic or persistent hypertension. And those symptoms can include headaches, sweating, palpitations, periods or episodes of panic. And so that diagnosis often involves measuring catecholamines and metanephrines in the plasma or in the urine. Remember that Cushing syndrome can be a cause of secondary hypertension, and that's going to be due to the excess cortisol production, which can lead to hypertensive situations. And the symptoms can be very diverse in these patients, ranging anywhere from weight gain to skin changes and muscle weakness. Remember that renal artery stenosis and thyroid disorders and several other disorders, which I will leave up to you to find on your own, are also causes of secondary hypertension, but renal artery stenosis is going to be due to that atherosclerosis or fibromuscular dysplasia, and that can lead to reduced kidney perfusion and secondary hypertension. And then thyroid disorders, both hypo and hyper, can affect blood pressure, and hypothyroidism can lead to elevated diastolic pressure, while hyper can cause systolic hypertension. And so in addition to those, remember, go up on your own or go out and look up the laundry list of things that can cause secondary hypertension. So, if you suspect secondary hypertension, what do? You get renal function testing. You want to make sure there's no CKD, signs of CKD or ESRD, make sure there's no evidence of that. You can assess it through GFR and urinalysis. You're also going to want to look at serum and urine electrolytes, looking for Conn syndrome. And so that can be a key test in ruling out causes of secondary hypertension. You're going to get 24-hour urine metanephrines potentially and catecholamines if you suspect a pheochromocytoma. That's a test you can order. You can look at cortisol levels and do a dexamethasone suppression test looking for Cushing's syndrome. And then you can also get renal imaging for pathology such as fibromuscular dysplasia, and atherosclerosis, both of which could lead to bilateral renal artery stenosis. And so you can get imaging for that to look for those pathologies. And then once you think you have found that pathology or identified that pathology correctly, you want to address that underlying cause, whatever it is, and then give the appropriate surgical intervention or specific medication or lifestyle modifications that the patient needs in order to live happily and healthily with whatever that underlying condition is. And so the prognosis of secondary hypertension is largely going to depend on the prognosis of whatever the underlying cause is, as well as the timeliness of that pathology's management. All right, lastly, we're going to talk about some things that can occur, some complications of untreated hypertension. And first, we have hypertensive encephalopathy. And this condition arises when extremely high blood pressures cause cerebral edema and brain dysfunction. So patients may present with symptoms like headache, confusion, and in severe cases, seizures and coma. And so it's very crucial to recognize this early as a potential cause of altered mental status so that you can promptly treat and reverse those symptoms. Secondly, you can get a retinopathy. So chronic high blood pressure can lead to changes in the retinal vasculature, which can result in blurred vision or even vision loss. So regular eye exams are also essential for patients with hypertension to monitor and manage those changes. Third, you can get a nephropathy, and that's a major concern. The kidneys are highly vascular organs, and prolonged hypertension can lead to kidney damage and eventually chronic kidney disease. And this is why monitoring renal function and controlling blood pressure is vital in hypertensive patients. You can also receive a stroke. So hypertension is a leading risk factor for both ischemic and hemorrhagic strokes. High blood pressure can cause weakening of the brain's blood vessels, leading to a hemorrhagic stroke. And that's going to really underscore the importance, again, of blood pressure control and reduction of this complication. You can get myocardial infarction, commonly known as a heart attack. And so hypertension can lead to coronary artery disease, which in turn leads to a risk of a heart attack. And that's obviously going to be a very life-threatening condition and a major reason why hypertension should be managed. You can also have cardiomyopathies. You can get type 2 diabetes. That's going to be a risk factor associated with developing type 2 diabetes. It's going to be chronic hypertension. And then you can also have that progression from hypertensive urgency, which we discussed very early on, and that can progress from urgency to emergency to encephalopathy. So that's why it's very important to manage the hypertensive urgency and to manage the hypertensive emergency so that you can prevent it from progressing to encephalopathy. And so remember what we talked about with those goals for blood pressure reduction. And on the slide here, I just have this little mnemonic to potentially help you remember some things about treatment and some things about complications. And so you can act to prevent trends in hypertension. So remembering the ACE inhibitors, ANRIs, ARBs, remembering your calcium channel blockers and your thiazide diuretics, and then that diuretic also tipping you off, and remembering that you can use loop diuretics as well. And so that's just kind of a lot of your first line meds right there. And then the trends is just organizing the complications alphabetically. And I believe the D, I think about the D being the ventricle of the heart as it squeezes out, and that helps me remember that myocardial infarction can be a complication of chronic hypertension if untreated. And so that urgency, emergency encephalopathy, remember those goals that we talked about, and remember that the exception is if a patient has aortic dissection, in which case you should very rapidly reduce their systolic to 100 and 120, and that's typically going to be done with IV infusions, and you're going to titrate that to where their blood pressure is controlled so that they stop dissecting. All right, and that's going to be it. Thank you guys for tuning into this lecture. I hope it was really helpful. Please remember to like, comment, and or subscribe so that we can continue to provide free medical education resources for students everywhere. And please feel free to drop us some feedback. We're always looking to improve. We'll see you in the next lecture.